endoscopy of India. Welcome, Dr. Das, for today's webinar. We also have Dr. Satyarth Chaudhary. He is the DM Gastro and consultant gastroenterologist at Merit. Dr. Chaudhary is an expert in various diagnostic and therapeutic procedures in the gastroenterology as well as in hepatology. Dr. Chaudhary is an active member of the Indian Society of the Gastroenterology. Dr. Chaudhary has the various publications in national and international journals, and he has been recognized with the several national and international awards. Welcome, Dr. Chaudhary, for today's meeting. We also have the Dr. Nitin Manglek, consultant gastroenterologist at the GB Pant Hospital, Delhi. Dr. Manglek did his MBBS and MD and DM from the GB Pant Hospital, Delhi. He has worked in the field of the gastroenterology for the last 15 years in various premier institutes of country like St. Stephen's Hospital, Delhi, Ram Manohar Lohia Hospital, Delhi. Dr. Manglek, he is currently working as senior consultant gastroenterologist in the Fortis Hospital, Noida, and he had various publications in the national and international journals. We also welcome Dr. Manish Kak, consultant gastroenterologist at the Manipal Hospital, Ghaziabad. Dr. Kak is a gastro in the Nehru Nagar, Ghaziabad, and has experience of more than 25 years. Dr. Kak practiced at the Gastro and Liver Clinic in Nehru Nagar and Manipal Hospital. He has completed MBBS from the JJMMC Medical College, MD from the Government Medical College, Srinagar, and DNV Gastro from the Tata Memorial Hospital, Mumbai in 2010. Dr. Kak is a member of the American College of the Gastroenterology and the Indian Society of the Gastroenterology. So we welcome all the eminent panelists for the today's meeting. And now I request Dr. Das to take over the session and moderate for today's session. Today we will have the two talks by the Dr. Das as well as Dr. Satyarth Chaudhary, followed with the two case presentation by the Dr. Nitin Manglek and Dr. Manish Kak. After that, we will have take the questions from the audience. So all the audience are requested to put the questions in the chat box so we can put these questions in front of our eminent panelists. Over to Dr. Das. Sir, please.
Thank you. I thank MSN Labs for organizing this session on ulcerative colitis. As we know that ulcerative colitis is a very interesting, for many years they were not many drugs which were being used, but now we have a plethora of drugs which can use for the treatment of ulcerative colitis. I am Dr. Kunal. I am Senior Consultant Gastroenterology and Hepatology in Manipal Hospital, Dwarka. So the objective of my presentation is to describe the relationship between JAK-STAT signaling pathway and pathogenesis of ulcerative colitis, to incorporate evidence-based research into clinical practice. That is the objective of today's session. So as we know, ulcerative colitis is an autoimmune, relapsing, remitting chronic disease of the large intestine, in which the lining of the colon becomes inflamed and develops tiny sores or ulcers. This is the normal colon, and this is the ulcerative colitis colon, where the surfaces become ulcerated. There, in between the normal surfaces, there are also present the ulcerated surfaces. In the ulcerative colitis patient has chronic inflammation of the large intestine, which further triggers the symptoms of ulcerative colitis, which are recurrent diarrhea, abdominal pain and cramping, fatigue, weight loss, blood in stools, intestinal blockage or sores. The prevalence of ulcerative colitis is around 44 per 1 lakh. So typically, ulcerative colitis patient will present as a bleeding PR, recurrent or once or twice, or may have typically patient will say a very urgency of stools, that the patient has to run to the stools, and many times in a day, maybe 4 or 5 times, and sometimes the initial part there may be some more stools, and in the subsequent there may be no shows even. Factors which cause ulcerative colitis. The factors which cause ulcerative colitis include some genetic factors, immunological factors, and environmental factors. It is overall an autoimmune disease, etiology of which is unknown, but we can speculate. The genetic factors such as some gene mutations, HLA types, or chromosomal changes may be there. In them, it is found that ulcerative colitis has increased prevalence in them. There are certain environmental factors such as bad eating habits, junk food, spicy food, lack of fiber in food, or poor lifestyle. They cannot cause ulcerative colitis, but in a patient of ulcerative colitis, they can make them symptomatic. There are always immunological factors such as autoimmune diseases in relation to other autoimmune diseases like PHC or thyroid or even diabetes. And also there is some change of gut flora or reduced gut flora may be present. These days, there have been a lot of studies on the microbiome of the colon, and which may be one of the factors in causing ulcerative colitis. So how do we, once we have diagnosed ulcerative colitis, how do we grade the ulcerative colitis? How do we clinically grade? It is clinically graded as mild, moderate, and severe. Mild disease is one where there is rectal bleeding, but the bowel motions frequency is less than 4 per day. It may be only initial damage of the mucosal layers of the large intestine, maybe only the rectum is involved. Second is moderate grade, in which rectal bleeding is there and the frequency of motions is 4 to 6 per day. Here, there may be increased cytokine levels due to tissue damage and recruitment of inflammation or immune cells, which results in inflammation and further tissue damage. Whereas there may be certain cases where it is very severe, the rectal bleeding is there, and the frequency of bowel motions is more than 6 per day. And there is also systemic response syndrome, a systemic illness, along with a hypoalbuminemia of less than 30 grams per liter. In this case, in severe, there may be exaggerated cytokines, which triggers further overstimulation of immune cells, leading to chronic inflammation and ulceration across the linings. So coming to now, once we have diagnosed, what are the complications of ulcerative colitis, which we have to be aware of? There may be certain complications which are acute in nature, which come suddenly on the diagnosis of ulcerative colitis, maybe at first presentation, or already a known patient of ulcerative colitis may present with a severe episode or an acute episode clinically. The most dangerous of all complications are toxic megacolon, which is a life-threatening complication. Here, the colon is dilated, and if you do a simple X-ray of the abdomen, we'll find that the colon is dilated, and the maybe more than around 8 centimeters in the transverse colon. It may lead to perforation. There may be hemorrhages. What are the chronic complications of ulcerative colitis that we must be aware of? The most important is that it can cause colon cancer. The frequency of colon cancer is 20% in 20 years. So we have to be aware of this, and we have to tell our patients accordingly that you should get your colonoscopies every 5 years or so that we can look out for any changes which can be suggestive of cancer. There are certain extra intestinal manifestations that are very important, and we must be on lookout for them. The most important are the skin lesions, the eye issues, and the liver disease, which may be associated with ulcerative colitis. Next slide, please. Now coming to a short about the pathogenesis. Under physiological conditions, there is usually a general hemostasis which is there. Normal microbiota in the intestinal lumen. There is the mucus layer, there is the epithelial barrier, and there is a laminar propria which is there. The commensal gut flora is there. Epithelial cells that line the interior muscles of the interior of the intestines, and the immune cells within the tissues which are there. So when there is this homeostasis is disrupted in a susceptible host, there may be certain specific environmental issues like diet, antibiotics, enteropathogens, stress, which may lead to disruption of this homeostasis, leading to the clinical presentation of ulcerative colitis. There may be certain genetic factors. The whole genetic factors, there are a whole lot of genetic factors involved, which include NOD2, ATG16L1, IRGM, IL-23 receptors, FUT2, and cardiology, CARD9. This results in hyperactivation of T helper cells, TH1 and TH17 cells. This increases the tight junction permeability and leads to uncontrolled chronic inflammation, leading to presentation of ulcerative colitis. Now, this dysfunctional response from the innate and adaptive system, the environment triggers, the microbiota, the epithelial barriers, the non-epithelial barriers, the genetic predisposition, the mucosal immune system, they all come together, leading to multiple inflammatory cytokines which are overexpressed during an episode, leads to amplification of the immune response, leading to phenotypic expression of disease and tissue destruction. These cytokines mediate the dysfunctional cell-cell interactions in the innate and adaptive response system. These days, because of the corona episode, people are very concerned and they understand the cytokine storm which is there, which is the key for all many of the diseases that we are facing today, including. So this is the schematic diagram where of the colon, where the epithelial cells are there, the mucinous cells are there, the commensal non-microbiota are there, which are non-pathogenic. First, there is a disruption of the light junctions and the mucous film over the epithelial layer. The mucinous, which is a protective layer, this is impaired, and there is defective regulation of the tight junctions. This causes increased permeability of the intestinal epithelium, resulting in increased uptake of luminal antigens. This once the luminal antigens come into being, the circulating T cells, which bear the integrin levels alpha 4 and beta 7, bind to this colonic endothelial cells microvasculature through the mucosal adhesion system, adhesion molecule 1, whose expression is enhanced. This leads to the upregulation of the inflammatory cytokines such as CXCL3, CX1, CXCL3, and CXCL8, leading to recruitment of further leukocytes, which perpetuates the cycle of inflammation which is there. So after understanding the pathophysiology, now we should understand what are the treatment goals. Before treatment goals, I will say one word about how do you diagnose a case of ulcerative colitis. The ulcerative colitis is diagnosed whenever a patient comes. Simple, you have to do some blood tests, which include CBC, ESR, CRP. You can do a simple X-ray abdomen. Once you have satisfied yourself that there is no toxic megacolon, you can go ahead and do the stool test, stool routine microscopy, followed by colonoscopy. Colonoscopy will tell you endoscopically the inflamed mucosa, and if you do a biopsy, on colonic biopsy, you will find that there are features of chronic inflammation and crypt disruption, which makes the diagnosis of ulcerative colitis. Also, by doing a colonoscopy, we know the extent of ulcerative colitis which is present, whether it is only in the rectum or in the left-sided colitis, which is E2, or it is pancolitis. Pancolitis is the most severe form of ulcerative colitis. So what are the treatment goals which of the ulcerative colitis? First and foremost is the induction of remission. Second is the maintenance of this remission. And third is prevention of complications, therapy-related allergies, intolerance, infections, lymphoma, steroid side effects, and disease-related extraintestinal manifestations, neoplasia, and toxic megacolon. So this is, we have a whole lot of ulcerative colitis drugs which are being utilized, which have been for in the last 7 decades. Starting from aminosalicylates like sulfasalazine, which is a prodrug, mesalamine and balasalazine. Corticosteroids, these days, again, steroids are in the focus. We have both the prednisone, the dexamethasone, and also some of the newer steroids which are less toxic, like budesonide. Also, we have the immunosuppressants, which we like azathioprine and methotrexate, which are being utilized. Antimicrobials, in a case of active disease, we might need to do antimicrobials, which include metronidazole, ciprofloxacin, doxycycline, and many others. TNF alpha inhibitors, these are the second or third line drugs to be used, biologicals, infliximab and adalimumab. They are very useful, especially in certain conditions. But at the same time, you have to be careful what you are utilizing. There may be specific indications. And also there's an expense which is attached to it. Then there are the JAK inhibitors, which we will discuss, and Dr. Chaudhary will discuss in detail. And the last but not the least, the surgery. There's always special, although it's not part of the discussion today, but there is always a certain category of patients whom might need an emergency surgery or an elective surgery for treatment of ulcerative colitis. So coming to the medical treatment first. First category, which is the most common category, is the 5-ASA or 5-amino salicylates. Here we have seen that the preparations include sulfasalazine, which by the bacterial flora and the bacterial azoreceptase is split into sulfapyridine and aminosalicylic acid. The sulfapyridine is rapidly absorbed. It doesn't have any therapeutic action, and but sometimes may have a systemic adverse effect of being allergic and other things. So alpha 5-ASA and its congeners acts through the lumen, which are poorly absorbed and has an anti-inflammatory action, leading to remission of ulcerative colitis. The aminosalicylic acid inhibits the COX pathway, the LOX, PF, bacterial adhesion factor, cytokines, and also inhibits IL-1 and TNF alpha. So the preparations of ASA are sulfasalazine and mesalamine. They are effective in reducing and maintaining remission. Topical mesalamine can sometimes be used in suppository form, especially for symptomatic relief, as well as it's very useful in cases of ulcerative proctitis, where the disease is limited to only the rectum. Left-sided colonic disease is also best treated with combination of mesalamine suppository and an oral aminosalicylate. Next in line are the corticosteroids. These are one of the mainstays in initiating remission. They are used in the acute treatment of moderate to severe colitis. They include both IV preparation as well as oral preparation. Budesonide is a new glucocorticoid which is entirely released in the colon, has minimal to no systemic glucocorticoid side effects. Dose of 9 mg per day for 8 weeks and no tapering is required. Also, in the acute phase, rectally administered steroid enemas may provide a very good symptomatic relief, especially for fears of distal UC. The corticosteroids act by this pathway, the GR pathway, the GRE, the gene transcription, the CRP hat, and mRNA, the anti-inflammatory protein are being produced by the corticosteroids. Now, next line of drugs is the thioplanes, which are quite effective in maintenance of remission. But the thing with thioplanes is that they are not appropriate as solo induction agents. Usually, they have a very slow onset of action, requiring 2 to 6 weeks for their action, and they are used for mainly which are very severe disease or steroid dependent or steroid refractory disease. The preparations which are available in the market are azathioprine or 6-mercaptopurine. And this is an important pathway by which they are utilized. Azathioprine, the 6-mercaptopurine pathway, and SGPRT, CGMP, and leading to apoptosis. This is the mechanism by which they are putting into action. Next in line is cyclosporine, which is more of a drug being used in renal transplant and liver transplant cases. But it is used as a third-line drug with severe ulcerative colitis, 2 to 4 mg per kg per day as a continuous infusion. But it has serious side effects in the form of nephrotoxicity, opportunity infections, and seizures. This is the pathological mechanism by which the cyclosporine pathway acts by the calcium channel blocker pathway. Now coming to the biologics, which are the anti-TNF alpha antibodies. They are IgG monoclonal antibody that is against anti-TNF alpha. It's a less toxic alternative to cyclosporine for patients with severe steroid refractory disease, effective for both induction and maintenance of remission. And preparations include infliximab, which induction of remission is 5 mg per kg body weight, and giving in weeks 0 to 6. Maintenance dose is 5 mg per kg body weight IV every 8 weeks. So this is the pathway by which they use. There are also newer biologics like natalizumab and vedolizumab which are being used, but they are mostly very useful for especially Crohn's disease, which have fistulizing Crohn's disease. So another therapy which is very important these days is especially in refractory disease is fecal microbiota transplantation. This has been, but still it is a research-based therapy protocol, and it is not still conducted. Is very few studies and the research protocols, and still not in a and there is no capsules. It is only in a few centers it is available. I will just borrow two slides from Dr. Chaudhary's presentation. Rationale for targeting JK-STAT pathway. These are the new drugs which will be discussed in detail by Dr. Chaudhary. JAK plays a role in cellular proliferation, differentiation, and immune functions. JAK-STAT is a major signaling cascade downstream for cytokine and growth factor pathways. The JAK family is JAK1, JAK2, JAK3. JAK-STAT is 7 transcription factors. JAK serves as transducer signals from cytokine receptors. JAK inhibitors interfere with JAK-STAT signaling. JAK inhibitors are usually effective in other chronic inflammatory conditions. This one I want to that why JAK-STAT pathway signaling drugs have come into ulcerative colitis, because many of the our rheumatology friends, especially in rheumatoid arthritis, psoriasis, these are the autoimmune disorders which are of the skin as well as the joint, are being utilized these drugs for a very long term with very good results. So JAK inhibition is a potential therapeutic target in ulcerative colitis, and Dr. Chaudhary will discuss the details for the same. Thank you very much. Now I will invite Dr. Chaudhary for his presentation. And questions we will take at the end of the all the 4 presentations.
Right.
Dr. Chaudhary, please.
Am I audible?
Yeah.
Thank you very much.
Sir, have you logged in with the 2 devices? No.
Yeah.
There is a lot of background noise, sir. One device has to be closed.
So there is no sound from this device.
So
So what you can do is I think you have connected mobile, right? Another mobile. Dr. Satya, sir, you have connected another mobile. So sir, you can switch on the video audio from the mobile and you can share the screen from laptop. Yeah. And sir, you'll just have to mute your laptop speakers so that there is no echo. Sir, please unmute your mobile phone.
now, can I start now?
You'll have to mute your laptop speaker. Speaker of your laptop, you just have to mute it, sir.
Can you go ahead with the slides from your side?
Yeah. No, sir, actually, sir, can you minimize your slides?
Yeah, sure.
Yeah, so sir, when you minimize your slides at the bottom of your laptop, in the taskbar, you will see a sound speaker symbol. You just have to mute it. The sound of your laptop. Can you see that? Sir, you are able to do that, sir?
Oh, I'm unable.
But actually, there is an echo from your phone and the laptop. So your laptop sound should be muted. The laptop sound, so that there is no echo, sir.
Now, can you please hear me?
Yeah, now I can hear you.
Now it's perfect.
I feel. So can you please share my slides? So it would be of great boon.
Yes, sir. We'll need the slides, sir. We don't have the slides with us. Your slides. I'll just check.
It is the same. So if the panel allow me, I can go ahead.
I have his slides downloaded.
Yeah.
I can do the slides if you give me the permission.
Yeah, sure, sir. Sure. That would be of great help. Thank you very much, gentlemen, for giving me this opportunity amid the ISG Con is also going on. So tofacitinib is, so ulcerative colitis is actually a multifactorial disease which has a relapsing and remitting pattern, which is characterized by the chronic inflammation due to the overactivation of multiple cytokines, which act through the JAK and STAT pathway. The core is the JAK and STAT pathway for this particular drug. So the genetic factors, environmental factors, they all act and ultimately lead to the mucosal damage. But how? There is release of the cytokines, cytokine activation receptors, and it further leads to a JAK and STAT signal transduction and release of the pro-inflammatory cytokines. So which further results in the progression of disease, and at the end is again a mucosal damage. So what is the rationale for targeting this JAK-STAT signaling? Why we all are talking about this JAK-STAT pathway? So the JAK-STAT pathway has four major roles to play. JAK-STAT pathway has a major role in cell growth, maturation of cell, differentiation, and hematopoiesis. Regarding the JAK-STAT pathway, if you see carefully,
can you, Dr. Chaudhary, can you see the slides?
Yes, sir. These are visible. You can go ahead with the next slide, please.
Yeah. Just tell me when you have to do the next slide. I will do it.
Sure, sir. Sure, sir. So why we are targeting this Janus kinase pathway? So it is very important. So this this JAK family has actually, there are four members, four intracellular tyrosine kinase enzymes, that is JAK1, JAK2, JAK3, and TYK2, and 7 transcription factors of the STAT family. So the Janus kinase serve to transduce signals from cytokine receptors. Actually, it is this Janus kinase is actually an intracellular membrane bound enzyme which helps in conversion of the extracellular signals to the intracellular response. Normally the cytokine bound with the receptors, which ultimately lead to the dimerization and induce the activation of associated JAK. again, these JAK phosphorylate the specific residue in the receptor cytoplasmic domain, which leads to the activation of STAT and phosphorylation of the STAT, which dimerize and translocate to the nucleus. Next, please, sir. So the JAK inhibitors interfere with the JAK-STAT signaling. They compete with the ATP for binding to the kinase domain of the JAK and inhibits JAK1, JAK2, and JAK3. There is also a very important thing which we should always remember, that these JAKs actually act in the pairs. JAK1, JAK3, JAK2, JAK3. Alone, only JAK2 can act. So these JAK inhibitors are used effectively in other chronic inflammatory conditions such as rheumatoid arthritis, psoriasis, psoriatic arthritis. So this JAK inhibition is a potential therapeutic target in the ulcerative colitis. So JAK1, JAK3 combination is involved in the transduction processes of IL-2R, IL-6R, which have a major role in the ulcerative colitis. Apart from that, you can see in the above slide that IL-2, IL-6, they again work with the JAK1 and JAK3 along with the STAT5 to act and ultimately result in the transcriptional changes. So here we need a potent drug which act on this pathway. So the Janus kinase inhibitor is actually a small molecule which acts only on the signal transduction. FDA approved this molecule for the rheumatoid arthritis in the year 2012, and the European Medical Agency approved this drug in the year 2017 for the psoriatic arthritis, and in the year 2018 the drug is approved for the active ulcerative colitis. So JAK is at the root of various immune and the inflammatory responses. Now, when talking about this drug, what are the different things which make it better available as compared to the previously available biologics? So we need to understand different aspects of the drug as well. It has a very good absorption. It helps in withstanding the gastric breakdown, and it has a bioavailability of 74%. There is rapid onset of action of this drug with the peak plasma concentration achieved within 30 to 60 minutes. And it has a steady state concentration of the drug for next 24 to 48 hours. So next slide, please. And the elimination is also quite rapid. It is only of 3 hours. The elimination is 70% by the hepatic route and 30% by the renal route. Now regarding the treatment goals, in the ulcerative colitis, we all want the remission or control or reduce the symptoms and arrest the progression of the disease. Next slide, please. So what are the different drugs which are available with us? As sir has already mentioned in his previous slides in great detail, so I think that I would skip it. So when I talk about the JAK inhibitors, they include this particular group include the available drug tofacitinib and baricitinib. So next slide, please, sir. Regarding the current treatment for the ulcerative colitis, we have a pyramid where we have the drugs ranging from amino salicylates to the cyclosporine depending on the severity of the ulcerative colitis. At the bottom line, we have amino salicylates. At the moderate, we have corticosteroids, azathioprine, 6-mercaptopurine, and on the top of the hill, on the top of the pyramid, we have cyclosporine, tacrolimus, and infliximab. So regarding it, the next slide, please. 25 to 40% of the patients with the ulcerative colitis remain primary or secondary non-responder to the conventional therapy. That is, we all are using mesalamine, azathioprine, and all our resorts, but still there is a place for the non-responders. To induce and to maintain the remission is again a challenge because it results in the decrease in quality of life, substantial morbidity, complications, financial stress in terms of the hospitalization, and patient has to undergo different surgical procedures. Sir, next slide, please. So as we have already discussed that this is a potent drug which has a role in the induction as well as maintenance of the ulcerative colitis and recently approved. Next, sir. So the tofacitinib has a role in the ulcerative colitis. So there is a study in the Octave 1 and Octave 2, a study of more than 1100 patients. In the patients with a moderate to severely active ulcerative colitis, tofacitinib was more effective in induction and maintenance therapy. So they have divided the patients in two groups. In the Octave 1, the induction of 598 patients, and in Octave 2, induction of 541 patients who had treatment failure with the conventional therapy. At the 8 weeks, because it is an induction study, there was improvement in the appearance of the lining of the colon. That is, there's significant improvement in the endoscopic scores. In terms of the symptom, there's a decrease in the rectal bleeding and stool frequency within 2 weeks. Next slide, please. For induction therapy, they have chosen a dose of 10 milligram twice a day. Tofacitinib helped the patient to achieve remission at week 8. 18% of patients taking 10 milligram of tofacitinib twice a day daily achieved remission at 8 weeks compared to the 6% of the placebo group. It relieved symptom quite early, as early as 2 weeks. So there is, you can see in the graph as well, there is significant decrease at the week 2. 30% of the patients taking tofacitinib 10 milligram twice a day result in the improvement in their appearance of intestinal lining compared to the 14% of the placebo. Regarding the clinical response at 8 weeks, 58% patients taking 10 milligram of tofacitinib twice a day experienced a clinical response at 8 weeks compared to the 31, again quite superior. Next, please. Maintenance therapy of the tofacitinib 5 milligram twice a day. Again, the Octave 1 and Octave 2 continued, and Sustain et al. Continued to assess the tofacitinib as a maintenance treatment and involve the patient who had achieved the clinical remission in the first 2 studies. So the endpoint was remission at 1 year. There was significant improvement in the appearance of the lining, that is endoscopic appearance at 1 year, and maintenance of the steroid-free remission at 6 months and 1 year. So you can definitely see in it. So these are the very important findings. The thing which is important is where we all want to know that what are the different side effects associated with this drug. It includes the headache, nasopharyngitis, nausea, joint pain. Apart from that, in the Octave 1 itself, they have seen that the infection rate is not very much high. It is 0.9%. The most common infection which the patients got was herpes zoster infection. The incident rate of the herpes zoster with the 5 milligram dose was 2.1, whereas with the 10 milligram dose, it was 6.6. So it is very important that these patients should be vaccinated. All the patients who are taking tofacitinib should undergo herpes zoster vaccination, especially the patient who have aged more than 50 years, chronic conditions, as well as immunosuppression. Regarding the different malignancies, non-melanoma skin carcinoma, that is the most common carcinoma seen with these patients apart from lymphoma, hepatic angiocarcinoma, and AML. We should also see carefully regarding the lymphocyte count and the neutrophil count of the patient. They should be regularly monitored every 4 to 6 weeks in the first visit and later every 3 monthly. It is a wonderful drug, and we can actually hope that it will change the whole scenario of the treatment of ulcerative colitis in the coming days or years. But there is still a lot work has to be done regarding the patients who are naive, because we don't know the result with the naive patients which would be put directly on this drug. This is still an area which needs to be completely seen or researched out. Thank you so much for your patient hearing.
Okay, thank you, Dr. Satya Chaudhary. You have been excellent information on tofacitinib. You have explained the pathophysiology and the octave 1 and octave 2 very well. And now I will like to invite Dr. Manglik. Are you ready with your case?
Yeah.
2 case scenarios which are of interest, and I think the clinicians can really relate to this. Dr. Manglik, please.
Thank you, sir. After listening to the basic science of ulcerative colitis, its pathogenesis and pathophysiology, and JAK-STAT pathway and the role of tofacitinib in patients with ulcerative colitis, I am presenting a case of a young female with acute severe ulcerative colitis, which was initially managed with conventional therapies. And when she did not respond to the conventional therapy, then it was upgraded, as we did in step-up approach, to biologicals, and then finally to tofacitinib. So this is a case of a young 29-year-old female without any significant past medical history, who came admitted to the emergency with a 7-week history of colicky abdominal pain, bloody diarrhea, which was stool frequency of 6 to 8 times per day. And in the last 4 weeks, she gradually developed rectal tenesmus and lost 2 kg of weight. So by the history, it is clear that she is suffering from acute severe ulcerative colitis with stool frequency of more than 6 and weight loss and tenesmus and abdominal pain.
Sir, we are not able to see your screen. Are you sharing your screen, sir?
No, Nitin, can you share your slides?
Okay. Just a minute. Now it's okay.
Yeah. Now it is fine, sir. Thank you.
Okay.
Please make the full screen, sir.
Go to slideshow and
okay. Slideshow.
Top orange. Yeah. Yes.
So also at the bottom there is a white strip. Please click on hide button.
Yeah. I'm doing that.
Okay, thank you, sir.
Oh, that's okay. So on examination, she had a fever of 101 degree Fahrenheit with a pulse rate of 104 per minute. Hemoglobin, she is mildly anemic with hemoglobin of 8.6, and CRP of 67. Fecal calprotectin was significantly high, and stool culture and routine investigation was negative for cytomegalovirus and Clostridium difficile toxin assay. So we rule out acute bacillary colitis as well as Clostridium pseudomembranous colitis. And so patient is having acute severe ulcerative colitis. Endoscopic assessment was done and it shows confluent deep ulcers up to mid-transverse colon. That means she is having pancolitis with E3 disease with complete loss of vascular pattern. That is ulcerative colitis endoscopic index was 6 out of 8. Histological analysis revealed crypt distortion, cryptitis, crypt abscess with lymphocytic and neutrophilic infiltration. That is suggestive of ulcerative colitis with activity. So the patient was diagnosed with acute severe ulcerative colitis, that is pancolitis, and was started on intravenous corticosteroids. By the 5th day of hospitalization, she shows some improvement and become apyretic and painless. But stool frequency remains the same with blood present in all the stools. So she is still having severe disease according to the Truelove and Witts classification. Therefore, we have 3 options at that time. We can give biologicals, we can give cyclosporines, and we can give tofacitinib. The treating unit started on with infliximab 5 mg per kilogram per day, and it was given on 0, 2, and 6 weeks. After 15 days, patient was free of fractal tenesmus and achieved a partial Mayo score of 2. C-reactive protein was decreased, and fecal calprotectin was also reduced. So she showed improvement by giving infliximab, but 8 months after starting infliximab, the patient lost response. So this is the problem with infliximab, that because of the development of antibodies, patient lose response and does not able to maintain the remission. So thus the infliximab dose was maximized to 10 mg per kilogram per day every 6 weeks. 4 months later, the infliximab levels were normal in the normal range, and the patient was in clinical endoscopic remission. But
sir, I think you have lost connection, sir.
no.
Yeah, continue, sir.
The blood analysis reveals an increased CRP of 17 and fecal calprotectin was again high. Endoscopy revealed continuous colonic inflammation with marked erythema, absent vascular pattern friability. That means she lost the response and again developed a relapse. In this context, it was decided to stop infliximab and to start tofacitinib 10 mg twice daily. 6 days after treatment start, the patient was free from pain and has 3 daily bowel movements without blood, and fecal calprotectin also decreased. The induction treatment with tofacitinib went uneventful. Patient does not have any side effect of that. Slight and transitory increase in the lipid profile was observed, and no other relevant analytical changes were observed. After 8 weeks, the patient was in clinical, endoscopic, and histological remission. For past 4 months, the patient has been receiving tofacitinib 5 mg twice daily for maintenance and remission. Remains free of symptoms and endoscopic activity. Thank you for your listening. So this is the way we step up the approach with conventional therapy in acute severe ulcerative colitis patient, and then we can choose either cyclosporine, infliximab, or tofacitinib. And tofacitinib is found to be quite effective in such a scenario. Thank you for your patient class. Sir.
Thank you, Dr. Nitin, for a very interesting and insightful case. Now, I will like to invite Dr. Manish Kak, who is a consultant in Manipal Hospital, Ghaziabad. He has saved best for the last. Dr. Manish, I can see your slides. Please go ahead with your presentation, with your case report.
Hello, everybody. Can you hear me?
Yes, Dr. Manish, please go ahead.
Okay, so thanks MSN and thanks my colleagues and thanks to all those people who are right now with us in this webinar. and we have had excellent 3 sessions before. So my work has been made a lot easier. We know about ulcerative colitis, we know severity, we know primary treatment, secondary treatment, and we know escalated treatment also. And as Dr. Manglik presented a case wherein this newer therapy, that is tofacitinib, was used. So it is a similar case which I will be presenting. And as Dr. Chaudhary rightly said, there is still a lot of gap in the management of protocol of this ulcerative colitis, wherein we cannot fit some patients. Some patients don't afford biologicals. They are very costly. And many times, I think 80 to 90% of patients, whenever we have talked to them about the biologicals, they refuse. And the primary reason being monetary issues. So if we have a molecule and if we have a drug which we can fit in somewhere in these moderate to moderately severe group of patients, I think that is a welcome change and a welcome step. So in the same process, this is the patient I would like to discuss. So 30 years old male with the IBD, or that is ulcerative colitis, pancolitis, without any extra intestinal manifestations. And this ulcerative colitis is known to have remissions, exacerbations. So this patient was in remission for 4 years. And for 1 year now, he has multiple relapses. And he has sought a lot of consultations, as these patients do. They go from a doctor to doctor. And sometimes they have relief and sometimes they don't have. And a treating physician has started steroids, but patient is not responding. So as we are, all of us, we treat these ulcerative colitis patients, once we have reached steroids and they don't respond, then there's a big question mark, what next? And that's where this patient was put on biologicals, that's adalimumab, for 3 months. And as such, he had no comorbid illness. So on presentation, stools were 4 to 5 per day with occasional blood. There was no pain, no fever. He had mild pallor, rest of the systemic examination was normal. Weight was 54 kg, vitals were stable. And he had mild tenderness in the left lower quadrant, and other systems were fine. Hemoglobin was lowish 10, microcytic hypochromic, TLC was okay, some platelets were, some level was increased, CRP was 56, and albumin was again low, 3.2. Viral markers were negative. Stool test was done. There were no ova or no parasites. C. difficile was negative, and calprotectin was very high, 1240. So this calprotectin tells us a lot of inflammatory activity is going on, and something needs to be done. And CT enterography revealed thickening of the rectosigmoid, again suggestive of colitis. Colonoscopy revealed pancolitis. X-ray was normal, Montauk's test was normal, negative. So patient right now was taking Pentasar 2 grams. He has taken steroids and some folic acid and Shalcor. So at this point, once patient is not responding to steroids, adalimumab was also given, but again, no response. He continues to have high inflammatory markers. CRP is high. His fecal calprotectin is high, and colonoscopy is showing pancolitis. Now, where do we go next from here? So I think this is the point where we are trying to bridge the gap in the treatment. The case was discussed and it was started on tofacitinib 10 milligram 2 times a day. And stool frequency was 3 to 4 in next 2 weeks. And after 3 weeks, there was no blood in stools. After 4 weeks, stool frequency came to 2 to 3 times a day, and as such, there was no any adverse event. And at 8 weeks, the stool frequency is near normal, that is 2 times a day. At 8 weeks, stools 2 times a day, there is no blood. Hemoglobin is 13, counts are normal. CRP has come down to 6. Calprotectin has come in range, and albumin has also improved. So maintenance, now patient is on tofacitinib 5 milligram 2 times a day, and he has been advised to follow after 2 months. As Dr. Chaudhary said, we have to look for his any counts, CRP, maybe some kidney functions, liver functions, we may do one follow-up. and see how patient is progressing. So that was a short case, and again highlighting the use of and of course need of this small molecule that we call it tofacitinib, which is a non-biological and a new drug in the armamentarium for treatment of moderate to moderately severe ulcerative colitis. And I think we can go to discussion and go on to the question answer session.
Okay, thank you, Dr. Manish Kak. And I am very happy that we have a set of 2 cases.
Great.
Excellent presentation from the 2 case reports. Now, can we take few questions? Do you have any questions?
Yeah,
from
sir.
the-
Sir, we have got around 17 questions.
Okay.
So should I ask one by one, or sir?
Yeah, you can
You
ask.
can-
send you on the
you can-
WhatsApp, sir.
You can ask the panel, whosoever is okay can answer. There's no
Okay.
issue.
Okay. Great, sir.
You can tell the name of the questioner and you can ask the questions. Anybody from the panel can take up the questions.
Doctor, yes, is ulcerative colitis autoimmune disease or related to food habits?
Okay, I will take that question. Ulcerative colitis is a autoimmune disease. It's a part of autoimmune disease, and it is, as I have mentioned in my slides also, that there are certain environmental factors, genetic factors, and immune factors which are important in the system. There are certain genetic genetic factors, especially the HLA, which are there, which can be they are more common in those diseases, but it can be said to be an autoimmune disease. Next question, please.
Great. Thank yeah. Dr. Dinesh Pal from Mawana, UP, please tell something about the portal vein thrombosis. I don't know how it is related with this ulcerative colitis. Portal vein thrombosis.
The portal vein thrombosis can be acute or chronic, and we see in setting of in cirrhosis, chronic liver disease, which is a prothrombotic state, and sometimes in acute pancreatitis in gastroenterology practice, we see portal vein thrombosis. Patients otherwise may have a thrombogenic state and they'll end up with portal vein thrombosis. So depends upon whether it is acute, whether it is chronic, whether it is associated with CLD, cirrhosis, or otherwise. Depends upon what next we have to do. Suppose it is a chronic liver disease with a chronic portal vein thrombosis, then we don't do much. We have to look for any hepatocellular carcinoma, which may be a predisposing factor. It may be a tumor thrombus, so have a look on that. Acute portal vein thrombosis will need different treatment. We may have to add a thrombolytic, we may have to add a low molecular weight heparin, or if it is a prothrombotic state, we may add something like warfarin. Otherwise, it is a huge thing. Exactly what does the questionnaire, what exactly does he want to know from portal vein thrombosis? This is in nutshell.
I would like to add, if you just can allow me.
Yes,
When
please.
we talk about the tofacitinib also regarding the octave trials and different trials regarding the tofacitinib, the portal vein thrombosis incidence is very, very low. They have only found 2 patients out of 1100 patients. So the incidence of the portal vein thrombosis with this drug is quite low. I mean, just negligible. So it is quite a safe drug. And definitely, as you have rightly pointed out, there are multiple conditions underlying with the disease state itself.
Yeah, the only combination may be that some autoimmune hepatitis, CLD, or maybe some disease may be relevant to the portal vein thrombosis. Anyway, we can go to the third question, please.
Yeah. One physician, Dr. Ashok from Andhra, he's asking, sir, how to diagnose ulcerative colitis? I am a physician. He had just written this.
Dr.
How to
Kunal has
diagnose,
already. Dr.
Yeah.
Kunal has already.
So I will take up the question since I did the ulcerative colitis. So as I have mentioned in my talk also, the diagnosis of ulcerative colitis will depend upon Mainly the endoscopic diagnosis by a test known as colonoscopy, in which there is a flexible tube which is light and camera is attached, and we pass it to the anus of the patient and we do the colonoscopy. If we find some features, we can do a biopsy, take the biopsy from the various areas of the involved endoscopic areas, and after the histological diagnosis, we'll confirm the diagnosis of ulcerative colitis. Now, depending upon the nature of involvement and the extent of involvement of the colon, we can further limit as E1, E2, E3, which is ulcerative proctitis, or left-sided colonic involvement colitis, or a pancolitis. So that is how we can diagnose this condition of ulcerative colitis. So next question.
Thank
please.
you, sir. One question, sir. Can mesalamine and tofacitinib can be combined, or both can be given together to the patient?
I think
would
yes.
like to,
Okay, Dr. Chaudhary, please.
sir,
Dr.
I would
Chaudhary,
like
please.
to answer it that we are using what we should also think twice, that what is the clinical scenario. The clinical scenario for the tofacitinib is in the active severe ulcerative colitis. So it is not commonly used in the remission. So there is no point of using the both drugs together.
Okay.
See, I think one thing is there that in the Octave trial, they didn't allow the AZA or mercaptopurines to be used, nor did they allow the biologicals. So that leaves the mesalamine apart. So as he said, that ideally should not be used because the indication is for severe, moderate to severe, where mesalamine has failed. But more important is that what should not be given, and that is the azathioprine, mercaptopurine, and biologicals. Actually, you should not give with tofacitinib.
Okay.
But what about steroids? Can steroids be combined with tofacitinib, Dr. Chaudhary?
No, sir. They should also not be used with the tofacitinib.
So any
I think
patient
they have-
who is
I
say
think they-
steroid refractory or steroid non response is not there, so you use only tofacitinib solo.
Solo, yes, sir.
I think in Octave probably they were allowing 20 to 25 milligram. I think up to 20
Sir,
to 25 in.
see-
I think in Octave they did allow.
See, the point is that we are using this drug mainly as a rescue therapy when we are using it as induction. And again, for maintenance of the remission, the chances of failure, it is like we are using the mesalamine even in the Crohn's disease. Just only mesalamine. We all know that azathioprine will work solely or given with the mesalamine preparation. So in the coming days, definitely there is a large scope. The studies would be conducted. When we give the tofacitinib alone or along with the combination, it is still a ground. We don't know.
I think yes, there is still scope for
No, we will
For
go
the
by what is
research.
the evidence in literature. Some studies may be conducted, but what is evidence in
Right
literature?
now, we don't
What are
have.
the studies which have been conducted? Are there any studies in combination, or all the
Most-
studies have been there with solo only?
They are with the soul only.
Fine. So the message is
Right,
that whenever you have to use tofacitinib in acute cases, then you have to use solo. Okay, next question, please.
Yeah, these are the major questions. Rest of the questions are being addressed, sir, in the presentation. These all were the basic questions on the dosage schedule and other thing. I think that has been covered very well in our presentation, sir.
Okay, so I will just ask the panel. Anybody can answer. What is your experience about the effectivity of tofacitinib in your steroid refractory or steroid dependent cases? We can start with Dr. Chaudhary first.
Yes, sir. So when I have initially used this drug in one of my first patient, where I have already advised, that was a female, I have already advised that you can kindly go for the colectomy. That is a better choice. The female was having pancolitis. So it is a wonderful drug. So it has saved at least 5 to 6 colectomies of my patients, and they achieved remission quite quickly. I mean, I have seen the difference within a week. So it is quite a useful drug for the patients who are having severe ulcerative colitis, who have lost their remission, having flares. Great drug. And in our second point is regarding our resource crunch areas, where all patients who cannot afford the biologics just had to undergo colectomy. Wonderful drug for them.
So, Dr. Nitin, I would like to ask you, in your experience, what has been the most common side effects of this drug?
Sir, I have tried this molecule only in 2 patients and recently only, and I did not found any side effect till now because I have used it only for 1 month. So till now, I have not encountered any side effect of this drug.
I have used this drug in different combinations, what other panelists and we all were discussing. Initially, I have used this drug with the azathioprine as well. It results in a significant immunosuppression. In my second patient, I have stopped the mesalamine as well. Everything I have stopped. So giving tofacitinib alone is, it gives you wonderful results. I'm giving the answer to that previous question also, because we don't have literature right now. These are only our experiences. Third, the most common, despite of stopping everything, when I was giving tofacitinib, I have observed that the patient was having alopecia on starting the drug. This was different. In the literature, they have given the nasopharyngitis, but given the circumstances when we have started the drug, in the last 2 or 3 months, you have also noticed in your OPD that there was a phase when the third wave of COVID was also there. The patient who were not having the COVID, they were affected from the common cold, nasopharyngitis, despite of testing. So nasopharyngitis is a commonly seen symptom in such patients, which is widely reported also.
Recently, I came across one patient of rheumatoid arthritis with ulcerative colitis. And rheumatologist has started his 5 milligram BD doses, and patient was taking for last 6 months without any side effect and not much of immunosuppression, and TL counts were within the normal range. But he was using it in the range of 5 milligram BD doses only, not in the what we use in the induction doses.
The good part of this drug is that there's a wide experience among the rheumatologists about this drug.
Yeah.
And my sense is also they are very satisfied with the drug, with the dosage that they are using, and they are very happy. So finally, Dr. Manish, I would like to ask you today, with all the evidences and the experience, where do you keep this drug and when will you start?
See, because the literature is not that robust, we are going by octave trial 1 and 2 that was there, induction and remission. So in that octave, what if I remember correctly, they were excluding the Crohn's disease patients and those patients who had fulminant colitis and toxic megacolon. So that group they have not added. And inclusion was patients who had failure of previous therapy. So that is important, because right now I think even in India also probably the approval is for those who have failing the conventional therapy. So if you have a patient who has failed on or has developed side effects to the conventional therapy, so side effects to steroids, or maybe or salicylates patient is not tolerating, or failure of previous therapy, there's where this tofacitinib is right now we have to fit it. And again in octave 1, they had allowed up to, if I remember, 20 to 25 milligram of prednisolone along with salicylates. That was in octave 1. And in octave 2, the steroids were to be tapered, and it was more of a alone tofacitinib in octave 2. So this is what right now we have. A regimen failed person or developed toxic side effects, and he's not a fulminant one also, and neither a toxic megacolon. So this is the in-between group where this molecule fits in right. That is by the octave trial.
Very well answered. So finally, I will like to ask Dr. Chaudhary that what precautions will you take before starting off tofacitinib? Seeing the side effect profile as well as the infections, and also understanding that the ulcerative colitis patients may be decompensated, or the active flare-up may have been due to some fungal infection or CMV infections. So what are the precautions you would like to take before you start tofacilative in any patient?
In fact, there is a list of precautions. First, to look for the lymphocyte count. Yet lymphopenia has not been very widely reported. I mean, the mark is 750. Regarding the absolute regarding the leukopenia, the count is 1000. Regarding the hemoglobin, the ideal is that we should maintain it above 9. Apart from that, we should also look for different drugs which are to be given along with it, like the drugs which induce CYP3/4 enzyme, ketoconazole, etc. That can lead to further increase in the, I mean, you have to reduce the dose. So these are the important things which has to be seen. Apart from that, as it is an oral drug, bioavailability is not a problem, doesn't has any role to do with different things which you eat, because see, so many molecules are available. We have to tell our patients that you have to take it fasting or after breakfast. So food doesn't has any role with it. So it is quite a safe drug in that way.
I think pregnancy also is somebody who's planning pregnancy, that group of patients has to be careful. They have to avoid.
They should avoid it. Contraindication in pregnancy.
So I think we had a very fruitful discussion. We had a very good 2 presentations and 2 very excellent case reports, and a very good discussion. So overall, I think we have come to this conclusion that well, ASA is there, melamines are there, but this is a very promising drug. And as we have seen in other other diseases, especially chronic hepatitis C, that an oral drug has supplemented the injectables drug with many complications. So we hope that this drug, more and more as evidence comes, that this can be one of the very good profile drugs, because it is an oral drug and very effective, and the action is also very quick. So I think we have come to this conclusion, and the message should go that we have a new kid in the block which has lot of potential. Just we are waiting for the evidence to come. Thank you very much. I think we can end the session here.
Yeah. Just to say, sir, thank you to all from the behalf of the MSN, for Dr. Das, Dr. Chaudhary, Dr. Nitin, and Dr. Manish Kak. It was a very, very elaborative, comprehensive discussion, and we are very sure, sir, these presentations and these discussions will help the number of the doctors for the better management of the ulcerative colitis in India. At the MSN, we are proud to announce the launch of the Tofadose 10, that we have launched tofacitinib 10 mg at the fraction of the price, sir. So soon we will be in touch with you with the more discussions, sir, with the more panel discussions on other gastro-related issues, sir. Thank you very much from our bottom of heart to all of you, sir. Thank you, sir.
Thank you very much. Thank you.
Thank you very much. I thank MSN for involving us in this panel discussion. Thank you very much.
Thanks, sir.